Hi everyone, I'm Amy Zellmer from Faces of TBI and welcome back to the Brain Health Online Summit Training Series. As you probably know by now, I'm a TBI survivor from Fall on the Ice in February of 2014, and I finally found Dr. Jeremy Schmoe in September of 2016. So him and I have been working together now for about 8 months. And as you know, that's sort of how the summit came to be. We saw a need in the brain injury community for more education on methods and modalities of alternative health care out there for those who are still suffering from the lingering effects of a brain injury. So today we wanted to bring you this bonus presentation to close out this amazing summit. And he's going to be telling you all about the vestibular system today. So Dr. Jeremy Schmoe is a Minnesota doctor and owner of Minnesota Functional Chiropractic and Neurology. And he works with patients from all over the state, the Midwest, across the US, and also he has international patients that fly in to work with him. He is board certified through the American Chiropractic Neurology Board and has completed a TBI certification program. He is a member of the ACA Sports Council and Minnesota Chiropractic Association. He is a speaker for the Carrick Institute of Graduate Studies, where he shares his expertise and presents advice on managing patients with concussion and brain injury. He has also lectured for the Minnesota Chiropractic Association, Northwestern Health Science University, the University of Minnesota Sports Performance Program, and various patient support groups. He has worked with multiple professional athletes with complex injuries and persistent post-concussive syndromes. He personally has had injuries from whiplash skiing accidents that led to debilitating vertigo and dizziness in 2011 and 2014. He has developed innovative exercises and rehabilitation based on his personal experience with concussion injuries. So welcome, Jeremy. How are you today?
I'm good. Excited to be here.
Yeah, it's kind of bittersweet to be closing out the summit here. It's been a great week. Amazing feedback, amazing presentations, and I'm just so glad that we were able to do this for everyone.
Yeah, it's been a really amazing week, just the feedback that we're getting from everybody from all over the place. So it's extremely exciting and excited to be here. So I guess tonight what we're going to do is we're going to talk about persistent post-concussive dizziness and talk about some of the things that I see in my office every day. And we'll kind of break down your case a little bit too and talk about some of the things that we found with you. But a majority of the patients that come into my office do have vertigo, dizziness, and disequilibrium. So those are really common symptoms that you see following post-concussion. So a majority of the patients we see at my office have these symptoms, and we really try and break it down into 5 different categories of the other symptoms that they have. So headache and migraine, nausea, emotionality, fatigue, and mild cognitive impairment are some of the most common things that we see in our office. So I guess really, what is going on in these patients? So you have a slip and fall, for example, your case, you fell on the ice and whiplash your cervical spine, hit your head into the pavement. And what are the things that can happen with that? Well, you can injure your peripheral vestibular apparatus. Have you heard of the peripheral vestibular system before?
Briefly. I've heard.
Yeah, so you have a peripheral vestibular system, but you also have a central system, and these systems have to communicate with each other. So when you have an injury, and say if you hit the back of your head, you could actually injure the peripheral vestibular system. A common thing that happens is you can have positional vertigo that develops after whiplash and trauma. So autoconia, or those crystals that are in your inner ear, can get kicked loose and then go into the canals. And then that can lead to dizziness and vertigo, which is really, really common after TBI. Well, some of the other things that you can happen is you can also have just positional vertigo and injuries that develop from changes in the cerebellum and changes in the vestibular nuclei in the brainstem. So really in my office, what we're trying to do is break it down into, is this more of a peripheral vestibular injury or is it more of a central injury? And commonly the patients that present to us have already had all the peripheral vestibular issues ruled out, and there's more of a central consequence. And we got to try and figure out what is going on in that system and come up with exercise to rehabilitate that system, which can be sometimes pretty complex. But with functional neurology and different techniques that we're using, we're able to localize where we think those injuries are, develop strategies to activate and get the nervous system to reintegrate again. So when you really break it down, the brain just really wants to know where you are in space. And we're always in gravity, and that gravitational load fires our muscles, and that feedback goes into the cerebellum. And you're comparing and contrasting what's going on with your body with what's going on with your visual system, your vestibular and your auditory system, and all those pathways integrate into the brainstem. And then they fire up into the midbrain, the thalamus, and up into the cortex to really let you know about where you are in space. And here's the thing: the system isn't perfect, and it's commonly affected with injury. So that's what we were seeing with you, where we would see changes with how your head would translate to the left and how your eyes would counter roll over to the opposite side. So it really wasn't an issue so much with your visual system, but how the vestibular and the visual were integrating together. Mm-hmm. And that's what we see and hear a lot from patients.
And I know, in my personal case, I had been seeing doctors for 2.5 years. By the time I found you, I went to the National Dizzy and Balance Institute, and they just told me it was positional vertigo and did the head roll thing. And that did nothing for me. I knew it was a positional vertigo because I didn't have like that rapid spinning sensation. Mm-hmm. It was more like I was just kind of constantly floating, for lack of a better word. And when I would lay down in my bed at night and close my eyes, that's when my eyes would move around. So I knew it was connected to my eyes. And the eye doctor couldn't figure it out. Neuro-ophthalmologist couldn't figure it out. The neurologist thought I was crazy. And that was the first thing you said to me was, yep, it's your eyes.
Yeah, and commonly what can happen too is when you develop whiplash injury to the cervical spine, you can have cervicogenic dizziness. So we're always trying to figure out, like, what is the main thing that's giving our patient these problems? Is it coming from the cervical spine? Is it peripheral vestibular? Is it central? Is it higher up in the brain? And that's what we do, is try and localize where in the nervous system is the problem and develop strategies to try and reintegrate your nervous system to allow you to know where you are in space again. One of the other things that I want to talk about is just eye movement in general. So really there's different visual reflexes. So these are called visually mediated reflexes. You have gaze holding, you have pursuits, you have saccades, you have optokinetic reflexes, which were definitely affected with your optokinetic response, specifically in the vertical plane. So when you're standing stationary and things were moving in front of you, I mean, that's what would make you feel like you were rocking and rolling on a boat.
Or like at a stop sign, just to kind of other people understand, like at a stop sign, if a car crossed in front of me, it would be like, whoa. And then that up and down motion was like scrolling on my computer screen or on my phone would sometimes just send me into like this, like, woo, the world's moving.
So these eye stabilization reflexes are extremely important. So you have vestibular ocular reflexes. You also have what's called a cervical ocular reflex. And then you have these optokinetic responses that allow your eyes to be able to stay focused on targets, when you're moving. And one of the things that happens is when you injure your brain, your cervical ocular reflex, the cervical colic reflexes get increased. So people will get tightness in their neck. So people will think that it's purely a cervical spine issue, but really it's coming from the fact that you injured the brain, and now you're not gating some of these reflexes appropriately through different circuits through the cerebellum. And then when your neck gets really tight, guess what happens? Some of the peripheral sensory nerves get activated, and then that leads to referral patterns up into the head, which leads to pain. So really the goal is to try and stabilize all these visual reflexes, improve the vestibular, and then do appropriate manual therapy into the cervical spine. And when you get those systems to integrate, that's when you really see headaches and nausea and some of the cognitive things that we see with people start to improve and get better.
Mm-hmm. I know when I came to you, like I said, I was 2.5 years out and I was still suffering from the whiplash pain. I still had a ton of neck pain. I didn't have my range of motion back yet. And you actually did ARP on me, the ARP treatment. I'll let you explain what that is. But you finally got my neck loosened up. And I think that in combination with what we did with my eyes, I mean, my dizziness went from like a 9 out of 10 to like a 2.
Yeah.
It was just, I had a quality of life back.
Yeah, and it happened very rapidly. I mean, this happened in 1 to 2 weeks that we saw your dizziness start to decrease. All right, so example for you, your cervical colic, your neck reflexes were heightened, they were increased. So going in there and doing manual therapy to your neck probably wasn't the best idea. You didn't know where your neck was in space.
Right.
So when we started to get your ocular motor and your vestibular system to reintegrate again, then your neck tone started to go down. And then we just helped it a little bit with doing this ARP wave therapy that we do in our office, which is basically just some very light electric stim into the cervical spine and then adding in motion with it. You know, and another thing that we did was work on some of these sensory cutaneous nerves that are right in through this spot here called Erb's point. All right, and start to dampen down the neurogenic inflammation in those areas. And then your headache started to decrease as well.
Yeah, like everyone watching, like there's a spot right here and mine's sore right now too. But like, if you just feel that right there, you can feel if it's tight, like it just pulls all the way through my shoulder and up into my head. And that triggers a lot of my stuff when that spot gets really rock tight. That's when I trigger a lot of my dizziness comes. It comes back to like a 4 out of 10, not a 9, but it comes back.
Yeah, so I mean, you have cervicogenic dizziness, all right, which is really, really common. We see that a lot with patients. So really, let's just kind of break down the basics of the vestibular system. I'm not going to go extremely in depth, but again, you have a peripheral vestibular system. And there's different pathways that allow you to respond to if your body is turning or rotating, or if your body is shifting left and right or shifting up and down. And the system that responds to this right here and this right here also responds to gravitational influences. So it's really important to know where your head is in space. All right. So in our patients after trauma, it's common to see head tilts, rotations, all right, and with a head tilt, you could really dig into that. You know, is it a change in a weakness of an eye muscle? Is it change in the peripheral vestibular system? Is it change in the central system? And that's really what we're always trying to figure out. And really, you know, your vestibular system wants to detect head motion and your head orientation in space. So it just wants to know where your head is in space, specifically in relation to your body, which is really important. And then it's important for just the automation of your balance reflexes. So you have to know where your head is, you have to know where your feet are, and if your body gets displaced, you have to fire appropriate responses to be able to move your arms and move your feet so you don't fall over. And another thing that it really likes to do is stabilize your vision, specifically with head motion. And that's something that you might have saw is where you're moving your head, or if you're walking, that things just look like they're moving in front of you, which is called oscillopsia. All right. Did you experience that?
A little bit, but definitely, like if I moved my head, like I wouldn't have been able to do what I just did.
Yeah.
even just moving my eyeballs could make me kind of dizzy.
Yeah.
But I do know what you mean. Like as you're walking and stuff looks like it's moving in front of you, I did experience a little bit of that. Like if I was walking outdoors.
Yeah, and then especially with.
It sometimes almost felt like I was in, you know, at the circus or at a fair, you go through those funny houses with the mirrors.
Correct, yeah.
That's sometimes what I felt like I was walking inside of.
Okay. Well, that's not fun.
No.
But, you know, one of the things that, yeah.
Like they call it the funny house, you know, it's not funny.
And obviously that's going to lead to fatigue.
Mm-hmm.
All right. So you're going to have fatigue, you're going to have brain-based fatigue. You're probably going to have nausea. Okay. So those are some of the things that we look at, you know, with our examination. So again, we look at the visual reflexes. It's really important for us to look at your autonomic integration, like heart rate, blood pressure in different positions, lying, seated, standing, which is something that we saw with you where, when you would lie down, that's when your heart rate would increase. You remember that?
Yep.
All right. A lot of patients that we see is when they go up to a seated and then a standing position, that's when their heart rate will increase. For you, it was opposite. So when you would lie down, then your heart rate would increase. And for me, that just tells me that there's some central cerebellar vestibular issues that were going on there. As when we took you out of gravity and then you were lying down, there was some impaired gating, and then your sympathetic system would elevate and then lead to an increased heart rate. And those are some things that we worked with working you through the tilt table.
And I felt like the heart rate stuff, I don't know if I would say it triggered my anxiety, but it like amplified my anxiety. Like, you have this like fluttering heart because your heart rate's high and then you think it's anxiety. Does that make sense? Like,
Yeah.
I noticed my anxiety has greatly diminished since we've taken care of a lot of that.
Yeah, so it's extremely important to also have, an interoceptive awareness of your own body, all right, which can get off with head injury. So we'll see people develop this increased representation, or they'll feel their heart pounding, they'll feel their stomach moving, they'll feel their insides tremoring, which is really, really common. All right, so you just know that there's issues going on in an area of the brain called the insular cortex. So the peripheral vestibular system fires right into that area, into the insula. So you'll see these different autonomic and gut complaints after people injure their vestibular system, which is really common. So I guess, when you really break it down to this, kind of go through what do we do with our physical examination? Like, what are the things that we look at in our office? So it's really important for me, if somebody's coming in with dizziness, do you think it's important probably to look in their ear? All right, so looking in the ear is good. Looking at dynamic visual acuity. So when people are moving their head, do they start losing lines on a Snellen eye chart? All right, looking at pupil size and pupil reactivity. All right, so it's really common to see changes in pupil size, a large pupil compared to a small pupil, changes in how those pupils react with accommodation or convergence. It's really important to do a funduscopic examination with people. So look at their retina and just see if the VA ratios, or see if there's changes in how that retina looks like it's moving. So I can actually look at the retina and see if there's any resting nystagmus, see if there's any different square wave movements. And sometimes you can't even pick these things up on a VNG test. So video nystagmography is something that we do commonly to look at graphing your eye movements out. And looking
at the big goggles.
Yeah. So looking at all the visual reflexes, looking at the optokinetic reflexes, looking at all the bedside vestibular reflexes. So if you move your head one way, do your eyes shift equal and opposite back the other way? So you have your rotational VOR, but you also have what's called a translational VOR. And with you had an impaired translational VOR over to the left, and that's something that we worked on. It's important to do positional testing. So put people back in different canal positions to make sure that they don't have positional vertigo, or BPPV, which is really common. So we see that a lot in our office, where people have not been tested for positional vertigo, and it's been months, years sometimes. All right. Looking at doing a cerebellar examination. So doing, finger to nose, rapid alternating motions is really important. And do you remember what we saw with you?
I couldn't touch, I usually miss my nose.
Yeah, so you had some subtle functional findings on the left, which told me that there, was probably an issue with gating out of your left cerebellum. All right. We really put an emphasis on the autonomic system. So one of the things that we see with people is that they get easily overstimulated with their rehabilitation. So whether that's vision rehab or PT or chiropractic or vestibular rehab, we have to have a good idea of, can the person tolerate what we're trying to do with them? All right, so what are some of the findings that we might see and changes in their autonomics? And that might be, well, you're doing a therapy and their pupils seem to start to really increase, or their heart rate goes up, or they start sweating profusely, or they start to get, more dizziness or nausea. So what we're trying to do is always trying to figure out that specific amount of rehabilitation that they can tolerate, and then not go past that limit. So push them to that limit, but don't let them go past that, to try and build plasticity and try and get their nervous system to integrate again. So
I remember, like with me, I was there like an hour and a half the first week, each session, and you never made me do any one thing for more than
yeah,
2-3 minutes. Like you would have me, touch my nose and then track my eyes, and then you'd have me do something like the art machine on my neck. I mean, like you gave me a lot. You would give the different components lots of breaks, and I think that was a key factor in how I reacted to those things.
yeah. So, we always say, I mean, the brain's multimodal. It takes in all this different sensory information and wants to integrate it together. So one of the things that we'll find with people is maybe one person does really, really well with doing some vision rehab. All right, maybe another person doesn't do very well when you just do some vision rehab. And maybe you need to layer on doing some proprioceptive feedback while you're doing a vision exercise or a vestibular exercise. So that's what we're always trying to figure out with people is how do we layer these different types of stimulations on top of each other to not overstimulate or just to reintegrate their brain again. So some person might do really well with doing more body-based exercises with their vestibular rehabilitation compared to just working on doing a gaze stability exercise. All right, so that's one thing that we're really good at in our office is trying to figure out what specifically does that person need without pushing their autonomic system too far. Mm-hmm. And one of the things that we also do in our office is we run blood chemistry on everybody. So we look at labs just to make sure that we're not missing anything. Underlying inflammatory conditions, anemia, magnesium deficiencies, vitamin D deficiencies, because if you're trying to do some sort of rehabilitation and that person is anemic or they're severely inflamed, maybe you might be able to make changes to that person. Maybe their vestibular issue and that issue that we find in terms of their blood chemistry don't matter to each other, but maybe they do.
Right.
So that's really important for us to take a look at that as well.
And sorry, with me, I remember my blood. I had. I'm trying to remember. I remember I had some inflammation. We found inflammation in my blood, and we had me start taking Temuro. Is that what it was called?
Yeah, it's just we found an elevated C-reactive protein level. All right, cardiac CRP. So we look at all these inflammatory markers, and for us, they matter. All right, so if we're trying to rehabilitate the brain, we want the brain to be in a state where it's not severely inflamed. So by looking at what's going on with blood chemistry, sometimes that can help us come up with the idea, does this person have these underlying metabolic components which would affect their rehabilitation? Or maybe we don't find anything.
Right. And I think what you're trying to say too is like if something is off, like a magnesium or vitamin D deficiency, you can come at that with a supplement and help relieve that problem. Is that kind of what you're getting at too?
You just broke up on me for 1 second. So
sorry. I was saying like if you do find something like a magnesium or a vitamin D deficiency, you can come at that with a supplement.
Yes, I mean, improving the diet, improving it with supplementation. One of the things that we commonly see, and we heard about this during our presentation, is the changes that happen in the gut after you injure your brain. Right. So we think about that. And then Dr. Sam Yannick went into, microglial cell activation in the brain and how some of these people are non-responders to neurological rehabilitation, and they have this microglial response that keeps going and leads to more and more inflammation and changes in their immune system and tipping on different sides and kicking into inflammatory pathways. So, we do take that into account in our office, especially if we see people that are non-responders to, different manual therapy, physical therapy, acupuncture, massage, all the different types of neurological stimulations, and they're not making improvements. There might be something that's being missed. Mm-hmm. All right. One of the things I want to talk about, which is actually really common that we see in our office after a concussion, is, sometimes systems aren't under functioning. Sometimes systems are over functioning.
Oh, like heightened or hyper?
heightened reflexes, heightened startle response,
Oh, yes. I
heightened,
have that.
heightened optokinetic responses. So people can have an abnormally increased optokinetic response. So their visual system and their vestibular system is overactive with motion in front of them. And sometimes people can feel like they're on a boat. So if they're running or they're moving or they have to deal with motion, this can lead to them feeling like they're being overstimulated and then feel like they might get a rocking sensation, that's something really, really common that we see in our office post-concussion. And that's something that you saw.
Yeah. I always just felt, because, when I say I had dizziness, a lot of people, there's so many interpretations of the word dizzy.
Yeah.
And people assumed I was like spinny, but my dizziness was more just like, I kind of stumbled and I always felt, like you said, like when you get off a boat after being on it for a day, you have that just kind of that constant moving. And when I put my shoes on at the door every morning, I'd have to hold on to the wall. Otherwise I would like tip over.
Yes, I mean, we just call that non-vertiginous dizziness. People have basically postural vertigo. So what's going on is they don't feel like they're spinning or they're rotating. They might feel like they get this sensation when stuff is moving around them or moving in front of them rapidly, or they have an impaired motion tolerance. And that's something that we commonly see after concussion in our office.
I remember telling you often too that I felt crooked, that I felt like I was like leaning like this. I remember that happening a lot too.
Yes, I mean your body. Well, that's cool.
It's gone.
Your body is going to respond to where it perceives it to be in space. So if you have changes in, say, this position here, you might see somebody rotated in space. If you see somebody with changes in the way that their eyes move this way or their vestibular system takes in information this way, you might see like a head tilt or some sort of lateral flexion in the body. If people have changes in the way that their brain perceives their head to be moving this way, they might feel like they're falling forward or falling backwards. So those are just, we call that changes in either yaw, pitch, or roll. And really the vestibular system it's gated by the cerebellum. All right, which is commonly affected after a concussion. So again, when you really, really break it down, there's gravitational feedback that's loading your muscles. You can injure your muscles. You could injure your cervical spine. You could injure the upper cervical areas, which have a lot of mechanoreceptors, which are giving feedback into the cerebellum and then talking with what's going on centrally in the vestibular system, the vestibular nuclei, which can lead to an impaired idea about where your head is in space, which can lead to all sorts of postural changes in the body. All right, and with our examination, that's what we're trying to figure out. We're trying to figure out what systems are affected here. All right, so you can see issues with neck pain, with changes in different visual or vestibular information. And you might have saw that with yourself, where you're in a certain situation where something's going on and then out of nowhere, your neck gets tight.
Yes.
And you're like, why in the heck did my neck just get tight? I'm not doing anything different. Something was just moving around me. I went to the grocery store, I was driving, and then my neck got tight.
Yep, all the time.
All the time. All right. So those are some of the things that we can help with therapies that we do.
What about when someone comes to you and they have other physical injuries, like, if they've been in an auto accident, they might have broken bones or other, major physical problems going on. How does that affect what you do, if at all?
Yeah, I mean, I would say a majority of the patients that we do see do have physical trauma and injury, whether it's from auto or, whiplash, slip and falls. I have so many crazy stories about the things that have happened to people.
I can only imagine.
Yeah. I have ceiling fans. I have snowmobiles landing on people's heads. Like, it's just every day there's something different. I even had a guy that was chasing after a goose and then he fell and then had a tree like hit him right into the neck. But yeah, so obviously when you have these injuries and people are in pain, pain is going to affect and change your brain. So pain is going to decrease your want to go and move and do activity. And your brain wants that motion. Your brain wants your body to move, and that physical activity drives your brain. And basically it's going to keep you sane. It's going to keep you human is with motion. So, changes in cervical spine, whiplash, trauma, and injuries. There can be obviously structural damage that can occur to the facet joints. There can be disc issues. There can be radicular symptoms. There can be, peripheral, just sensory neurogenic inflammation that come from nerves that are right underneath the skin that can lead to referral pain up into the head. And all those things matter. So if you're trying to do, different types of rehab exercises and that person is in severe pain, trying to get them out of pain before you do your activity would be a really good idea. And that's something that we do in our office. And we did that with you. So before we could get you back into doing more yoga activity and more physical therapy exercises, we had to decrease your pain. And a part of that was fixing the way that your vestibular system integrated with your eyes, which allowed your neck to loosen. So we could go in there and manually work on your cervical spine and not have it just go right back into being tight and be in pain.
Yeah. And, David George talked a lot about the whole chronic pain, the cycle of chronic pain. And, I think there's so much more to chronic pain than people think. They don't realize, I can't tell you how many times you or Cassie would touch me like somewhere in here and I'm like, ow, that really hurts. But I had no idea it hurt until you touched it. So chronic pain, I think, causes more problems than people realize, after a brain injury.
Yeah. And then, if you're in chronic pain, that's going to lead to anxiety. That's going to lead to depression. That's going to lead to fear responses. That's going to lead to different areas in the limbic system becoming hyperactive. And then that's going to lead to changes in your autonomic system. So excessive firing of your sympathetic system, your fight or flight responses. And guess what? That loops back around. That leads to more pain and dysfunction. And also with dizziness, anxiety and depression play a huge role. So you can get dizzy just from having anxiety and depression. Yeah. So obviously anxiety and depression are changes in the brain.
And I think vice versa.
Yeah.
Dizziness can trigger anxiety too.
All right. So, there's a lot of patients that have anxiety that are coming from central vestibular changes. If you don't know where you are in space, that can lead to anxiety. All right. But you could also have a brain injury that leads to anxiety, and that leads back into more dizziness. All right. So there's all these different, factors, these webs, this neuromatrix that we have to look into that can affect an individual person. And that's why I had Dr. Ali Wagner on the summit to talk about, anxiety and depression. And she's a sports psychologist. So I think, cognitive behavioral therapy, energy work, things that can help you deal with, fear and anxiety and depression are huge for helping people recover from these injuries.
Right.
So, that, for me, that was really the whole point of the summit, was to try and bring in and integrate all these different therapies together, chiropractic, manual therapies, physical therapy, cognitive behavioral therapy, yoga, meditation, breathing exercises, nutrition. So I just think there's a lot of things out there that people can add into their program to help them get better faster.
Absolutely. And I think, so many people don't understand what's out there. We trust our doctors, so to speak. And if you have a neurologist telling you there's nothing more they can do for you, you kind of believe them. I was at that space, and fortunately I found you, or you found me. So that's where my passion comes from, is I want everyone to know this stuff exists and you can get better. I had resolved to the fact that I wasn't getting any better. I'm like, okay, this is the best I'm going to be. Sucks, but it is what it is. And after working with you just 2 weeks, I drastically changed my life. I mean, I went from not being able to do anything for more than like an hour or two a day to being able to get like 5 to 6 hours out of my day.
Yeah. And that's, that was also my other idea with this summit is, I mean, there's really highly trained professionals that have more advanced training in different techniques. So say, for example, you have chiropractors, but then you have some chiropractors that have done more advanced training in traumatic brain injury. You have physical therapists, but then you also have neuro PTs. All right. You have optometrists, but then you have neural optometrists that are more advanced in terms of their work with traumatic brain injury. All right. So I just think, by bringing all of this work together and combining it with sports psychology and cognitive work and all the other things that we listed, I mean, that's what people need.
Mm-hmm. And just a feeling of knowing that they're not crazy. The balance and dizziness is real, and the anxiety is real. And like you even just talked about the stiff neck, like, yeah. I mean, you're so right. Like you just be sitting there watching, like even just watching a television show, and my neck would get tight, and it's like, am I sitting wrong? Like, what am I doing? And in reality, it's that eye movement stuff and the anxiety. So there's it's just so, concussions are just so intense in what they can affect.
It's, some of the things just blow my mind because, I've had 3 concussions, and after my one in 2011, that's when I started getting just a lot of vertigo and dizziness. And I actually lost about 50, 60 pounds from just feeling so nauseous all the time. And I saw the changes that occurred in my gut function. And then next thing you know, severe anxiety, feeling like my insides were tremoring and shaking. Dizziness with visual information moving in front of me, headaches, right? So these things, they just derail people's lives. And I just think there's so many different therapies out there that people can do, and you're not just, stuck the way that you are. There's things that you can do to help, to help make improvements, to get yourself more functional. And some people think that their system is broken, but guess what? I mean, there's neurologists out there and chiropractic neurologists that they can actually tell you if your system is broken or not. So that's one thing that's good to know is, are you broken or are you not broken? Can your system actually be fixed, or do you have to try and compensate for having a reflex that just doesn't work anymore? So I do see people that have systems that are unfixable. All right. But there's still things that you can do by working with other systems to upregulate them to help the other system that isn't functioning appropriately.
Right. And I remember, I think it was the day of my exam even, you told me that this is what's going on and this is what's happening, and nothing's broken. I remember you telling me that. You said nothing's broken. This is all, we can fix this stuff. And that was super reassuring.
Yeah. And that's what's cool about this examination is being able to see if the systems are broken or if they're not broken, because then well, how much energy do I really want to put into trying to get better, I guess. Am I just going to keep doing these exercises that people told me to do? Am I going to keep doing these the rest of my life? Like, what's the plan? What's the out? Where are we going? What's the actual issue? So that's why I get so excited about all this work.
And I think one of the questions that I was asked several times during the summit, and I think you just kind of segued into that without trying, was I got asked a lot, like, so does this stuff stick? Like, once you get the dizziness under control, like, do you just have to keep doing this stuff forever, or does it like stick? And I mean, in my case, it's definitely stuck. I've had a couple things that have triggered it. And I knew in that situation that it was triggering me, and then I had to come back and we did more exercises. But for the most part, it's all like stuck. Yeah. So if you want to kind of address that.
Yeah, I mean, you can fix these issues if you're very specific with your rehabilitation, and you can stabilize them. So they're totally going to be different for each individual person. Me, for example, I have flare-ups all the time. So I'll have things happen out of nowhere. And I know I kind of know what my triggers are. And then I know what to do to help stabilize myself. And I know what things are going to make me better. I know what things are going to make me worse. It's nice to know that. And Dan Sexton really touched on that in his talk, where he's talking about he knows his body so well that he can go in, and even in the middle of a game where he's playing in the KHL, he'll do some of his eye exercises if he feels a little bit off, and then his game is right back on. So I'm kind of the same way. So, you can't say, because it's so specific for each individual person, but a lot of times you can really get people a lot more functional where they know what's going to basically throw them off, and they'll know the exercises that they need to put themselves back in order again.
Yeah. And I think that's where I am. There's times when I feel just a little bit off, and then I can do my own exercises. And then like that incident I had where I was driving and those reflectors, those vertical, what are those called again? Up and down.
The optokinetic response.
Yeah. So they were coming at me for an hour and a half driving on the freeway. And I mean, I was done when I got to the hotel, and the rest of my trip, I was like falling over and running into things. So as soon as I came back to town, I went and you did some more intense stuff with me, and it calmed it right back down. So I know there's that reassurance that I know that we can calm it back down.
Which is a good feeling to have.
Yes. It's not like permanent.
Yeah. So you don't just, completely go off the edge and go into these fear anxiety responses and things like keep going and going and going and going. So.
Yeah. Well, Jeremy, was there anything we didn't touch on that you wanted to talk about with the vestibular?
I think we got everything. I didn't want to go into all the nitty gritty. I kind of wanted to be more of a conversation between me and you about some of the symptoms that you had, some of the things that I had, but I think we hit on a lot of the major points. And I guess the main idea is that there's things that can be done. All right. And, this summit isn't about just promoting, functional neurology or promoting chiropractic. It's about promoting everything that you can do to help improve brain health, whether that's, manual therapy or acupuncture or, massage, whatever. Just, you have to know what's going on individually with that person. Then you can plug in different types of therapies that could help integrate their nervous system and make them function better.
That, and I think from my perspective, is if your doctor isn't helping you, if he or she isn't listening to you, if they're telling you, no, that we can't help you, there are doctors out there who will listen to you. And like Jeremy touched on this before, like you might have a system that is broken, but they can help you like get those coping skills or get some other mechanisms working better to compensate for that. So I just don't want anyone to give up hope. I don't want anyone to ever stop looking for a doctor that can help them, because as I found, they're out there. So
yeah.
Awesome.
I think that's good. Yeah, thank you.
And the summit has just been, it just was out of the park. It was awesome. Such amazing feedback. Thank you, Jeremy. This is a huge joint effort to bring this to you guys, and it's just been phenomenal.
And if people, in the future want other presenters, other speakers, just let us know, and we'll try and get those people for the next summit that we do.
Yep.
So.
All right. Well, thank you, everyone. Yeah. Thank you for being a part of the summit. Remember, you're not alone in brain injury. And if you missed any of the recordings, you can purchase all of them for $29. You get all 22 speakers' presentations. You have access to those virtually forever. You have the video and the MP3 options. So the proceeds from that are going to the Brain Injury Association of America. And if you have any questions for any of our presenters, please feel free to reach out to them. They've definitely enjoyed hearing from you guys. So thank you, everyone, and thank you, Jeremy.
Thank you.